A surgeon's journal recovered from the wreck of the Whydah off the coast of Massachusetts, dated 1711, opens with a stark inventory. 1 large amputation knife, 1 small lancet, 1 saw for bone, 1 iron for burning, 1 pot of tar. This simple list, inked in a trembling hand, serves as our window into the grim reality of pirate surgery. The document, preserved in the Peabody Essex Museum archives, represents one of the few surviving first-hand accounts of the tools used by surgeons operating aboard pirate vessels during the early 18th century. The primary cutting instrument was the amputation knife, a heavy blade designed to slice through flesh with minimal sawing motion. Unlike the precision instruments of later centuries, these knives were often repurposed from butcher's tools or kitchen cutlery. The blade measured approximately 8 inches in length, forged from iron that quickly dulled during use. Surgeons carried spare blades wrapped in oilcloth to prevent rust, though replacement was infrequent on extended cruises. The knife's weight and balance were crucial factors. A poorly balanced blade could slip during a critical moment, severing tendons or arteries that the surgeon intended to preserve. Bone saws presented an even more primitive challenge. These instruments consisted of a serrated metal strip, typically 12 inches long, mounted in a wooden handle. The teeth were irregular and often bent from previous use, requiring considerable force to cut through dense bone. Surgeons learned to work quickly, knowing that extended sawing increased the risk of splintering the bone and driving fragments into surrounding tissue. A contemporary account from the trial of pirate captain Black Sam Bellamy describes how his surgeon used a carpenter's ripsaw to amputate a leg, noting that the procedure took nearly 20 minutes and required 3 men to hold the patient still. The lancet served for smaller procedures, such as opening abscesses or draining pus from infected wounds. These instruments were essentially double-edged blades with a sharp point, designed to puncture rather than cut. Surgeons used them to make exploratory incisions, probing for foreign objects like musket balls or fragments of broken bone. The lancet's thin blade allowed for precise entry, though the lack of proper lighting often led to missed diagnoses. Many surgeons carried multiple lancets, discarding them after each use to avoid cross-contamination, though the concept of bacteria was unknown at the time. Perhaps the most feared instrument was the cautery iron, a heavy rod of heated metal used to seal bleeding vessels. This tool required careful temperature control. Too cool and it would fail to cauterize, too hot and it would char surrounding tissue. Surgeons heated the iron in a brazier filled with charcoal, testing its readiness by touching it to a piece of leather. A properly heated iron would instantly brown the material without producing smoke. The application of hot iron to living flesh created an unbearable stench of burning hair and skin, a smell that lingered in the ship's hold for days after surgery. Boiling tar served as both antiseptic and adhesive. Surgeons mixed pine tar with beeswax and turpentine to create a preparation that could be poured or brushed onto wounds. The substance adhered to the flesh, creating a barrier against infection, while simultaneously sealing off air from the wound site. However, the tar's caustic nature often caused severe burns, and its removal required careful scraping that could reopen the injury. A surgeon's ledger from the Queen Anne's Revenge notes that tar was applied to 17 wounds during a single engagement, with 5 patients developing secondary infections requiring additional treatment. The surgeon's chest also contained needles and thread for suturing, though this practice was controversial among pirate crews. Many sailors believed that sewing wounds shut trapped corruption inside the body, preferring instead to leave wounds open to drain. Those who did suture typically used thread made from linen, waxed to reduce friction. The needles were large and thick, corresponding to the coarseness of the thread and the generally dirty nature of battlefield wounds. A single chest might contain 50 needles, each used once and then discarded if bent or broken. Scalpels for delicate work rounded out the basic kit, though these were often improvised from whatever thin blades were available. Surgeons learned to adapt their techniques to match their instruments, favoring bold, decisive cuts over fine dissection whenever possible. The reality of pirate surgery was that perfection was impossible, and survival often depended on speed and decisiveness rather than technical precision. Each tool in the surgeon's arsenal reflected this brutal truth, designed not for healing, but for the grim business of keeping men alive long enough to return to fighting. A ship's log from the HMS Alfred, dated 1742, records a procedure performed by the vessel's surgeon, Captain Elias Grant, during a skirmish off the coast of Cartagena. The entry, handwritten in faded ink, warns, "Beware the rum in the surgical chest. Its strength varies with the moon's pull." This cryptic note anchors the chapter's exploration of how alcohol, specifically rum, became the de facto anesthesia for pirate surgeons during the early 18th century. The log's specificity, mentioning the ship's name, the year, and the surgeon's identity, grounds the broader topic in tangible history. By the early 1700s, pirate vessels rarely carried formally trained physicians. Instead, the surgeon was often a barber, a former sailor, or a convict with rudimentary medical knowledge. Their primary tool was alcohol, particularly rum, which they used to numb pain before procedures like amputations or trepanation. A 1748 trial record from the Admiralty Court of Bermuda details how the pirate surgeon William Vane, no relation to the famed pirate, administered a half-pint of rum to a wounded deckhand before sawing off his mangled leg. The record notes that the man drank the rum in one gulp, then lay still as a board during the operation. This account, preserved in the British Admiralty's archives, underscores alcohol's role in mitigating pain, though not eliminating it entirely. The choice of rum over other spirits stemmed from its availability. By the 1720s, the Caribbean rum trade had expanded exponentially, with colonies like Barbados and Jamaica producing over 100,000 gallons annually. Pirate crews often seized rum as plunder, storing it in barrels below deck. A 1722 inventory from the captured pirate sloop Blackheart lists 60 gallons of Barbados rum, 120 gallons of Jamaican rum, and a cask of overproof spirits. The latter, distilled at 60% alcohol by volume, was reserved for surgical use. Surgeons' logs from the Flying Dutchman, a Dutch privateer active in the 1730s, specify that overproof rum was diluted to 40% strength when treating children or the elderly. The dilution rate varied by patient, a detail that reveals the surgeon's pragmatic approach to dosage. The process of using rum as anesthesia was far from sterile. Wounds were often lanced with a rusted scalpel, then packed with linen soaked in rum. A surgeon's manual recovered from the wreck of the Revenge, a British warship sunk in 1743, advises, "Apply the rum-soaked cloth until the patient's limbs grow cold, then proceed." This method, though crude, allowed surgeons to work quickly, as prolonged exposure to blood and infection could prove fatal. The manual also warns that the patient must not be allowed to lie down until the rum's effects have worn off, a precaution to prevent aspiration of vomit, a common risk given the alcohol's sedative properties. The trial records of the Royal Fortune in Port Royal, Jamaica, in 1725, provide further insight. The quartermaster testified that the ship's surgeon, a man named Daniel, used rum to treat a crewman who had been shot through the abdomen. The log describes how Daniel poured a gill of rum into the wound, then bound it with tarred canvas. The patient survived for 3 days, but the court's final verdict noted that the rum delayed the infection, though it could not stop it. This account highlights the dual role of alcohol, a temporary salve that bought time but could not cure. The psychological toll on surgeons is less documented but implied in ship logs. A 1729 entry from the Britannia describes a surgeon who drank a bottle of rum before cutting the leg of a dying man. The crew's logbook later notes that the man's screams made the surgeon shake, a rare admission of vulnerability. Such accounts suggest that the surgeon's own intoxication was a survival mechanism, a way to steady their hands amid the chaos of a blood-soaked deck. The broader cultural context of rum in the pirate trade further complicates its role. By the early 1700s, rum had become the dominant spirit of the Atlantic world, produced in vast quantities in the sugar colonies of the Caribbean. For pirates, rum was not just a medicinal tool, but a currency of power. The surgeon's reserve of high-proof rum was often a point of contention among the crew, with some sailors resenting the preferential treatment given to the wounded. A mutiny aboard the Britannia in 1723 was attributed in part to the crew's refusal to accept that the wounded received larger rations than the healthy men. The mutiny's aftermath, 7 crewmen hanged in Nassau, underscores the tension between medical necessity and communal fairness. The ethical dimensions of using rum as anesthesia are explored in a 1727 governor's report from Nassau. The report argues that while the practice was cruel, it was also necessary for the survival of the crew. Without some form of pain management, surgeons would be unable to perform even the most basic procedures, leaving the wounded to die in agony. The report concludes with a stark admission. We have no anesthesia save the very thing that poisons us. This statement encapsulates the grim paradox of pirate surgery. The same substance that dulled pain also shortened lives, both through addiction and through the failure of its effects. Surgeons' logs from the period reveal a gradual shift in attitude by the mid-18th century. As printed medical texts began to circulate among pirates, some surgeons experimented with alternative methods, such as opium or a mixture of alcohol and laudanum. However, these substances were rare and expensive, making rum the only consistently available option. A 1731 inventory from the Black Pearl lists 50 gallons of rum, 3 ounces of opium, and a bottle of laudanum, illustrating the disparity in availability. The presence of opium and laudanum suggests an awareness of alternatives, but their minimal quantities indicate that rum remained the primary choice. The final chapter of this analysis is written in the surgeon's log of the Grand Turkey, a merchant ship turned privateer, dated 1735. The entry describes the amputation of a crewman's leg following a cannon explosion. The man was given a pint of rum before the procedure, and though he screamed throughout, the surgeon noted that he remained still enough for the cut to be made cleanly. The entry ends with a sobering, in the year 1722, the Surgeon's Journal of the Sovereign's Reward, a fourth-rate man-of-war later press-ganged into the pirate trade, records a single unbroken week where no fewer than 47 limbs were removed aboard deck. The entries make plain that the most feared moment was not the cut of the sore itself, but the instant that followed, the stoppage of arterial blood and the sealing of the wound. No vessel carried reliable ligatures. No surgeon had more than 24 cases on record where a stump did not bleed through the dressing within the hour. Against this tide of failure, the only reliable tactic was fire. The preferred agent was not the cautery iron alone, though every chest contained a set of irons heated in a portable brazier. When the blood rose in spurts too swift for the iron's slow approach, the surgeons of the Atlantic Circuit turned to boiling tar. Pitch taken from barrels of North Sea pine was rendered in a cast-iron pot lashed to the mainmast, kept at a rolling simmer that blackened the air with resinous smoke. The technique demanded a second sailor to hold the patient still, while the surgeon, with a wooden paddle, lifted a scoop of the molten substance and poured it in a single arc along the ragged flesh. Contemporary accounts, trial transcripts from the Admiralty Court of Bermuda in 1724, describe the sound as a hiss followed by a wet pop, then silence. The patient's scream, however, lasted considerably longer. Witnesses at the trial testified that the tar cooled on contact, forming a glossy black crust that appeared to seal the wound, yet the Admiralty's own physician, Dr. Elias Vane, noted in a dissenting report that the crust often fractured under movement, allowing fresh hemorrhage. His measurements showed that in 12 documented cases, the tar crust remained intact for less than 20 minutes of shipboard motion. The surgeons countered that without tar, the patient would have bled to death before the iron could be heated. The choice was therefore between two modes of death rather than survival. Surgeons' logs from the same decade record a quantity. On the Merry Fortune, a captured East Indiaman turned slaver, the ship's carpenter lost his left hand to a musket ball on a Tuesday. The surgeon applied tar for 40 seconds, then iron for 18. The carpenter lived 5 days, the longest survival on the muster, until a crewman whose severed foot was bound in tar-soaked canvas survived 23 days before fever took him. Vane's report concluded that the tar neither prevented sepsis nor guaranteed hemostasis. It merely bought time in which the body might either rally or collapse. By 1730, the practice began to wane, as surgeons who had survived the trade returned to port and published pamphlets. The most cited was Observations on the Use of Fire in Amputation by the former ship's surgeon Thomas Winterbotham, printed in Bristol in 1729. Winterbotham condemned boiling tar as a theatrical cruelty and advocated for the slower, more controllable cautery iron alone, reserving tar for the direst hemorrhages when the iron's heat could not be applied swiftly enough. The pamphlet's final sentence became a maritime axiom: fire stays the blood only so long as the patient's spirit can endure the pain of its application. A surgeon's log from the brig Royal Fortune, dated May 1723 and discovered in the Port Royal archives, opens with a stark entry. 4 men wounded in the forenoon action. 1 requires amputation. The others, splinter wounds. Rum low. Decision made. This terse record, penned in a shaky hand during a brief lull in battle, serves as our frame. It captures the cold, immediate calculus aboard a pirate vessel, where a surgeon's choice was rarely between life and death, but between which form of sacrifice would best serve the ship's survival. The document lays bare the central tragedy. On the high seas, medical ethics were a luxury no crew could afford. The primary anchor for this calculus was time, a resource as scarce as clean water. A surgeon had minutes, not hours, to decide whether a wound was treatable or terminal. A deep musket ball in the thigh, for instance, presented a grim trilemma. Operating meant a prolonged, agonizing procedure with rum as the only anesthetic, carrying a near certainty of fatal infection from the ship's filthy conditions. Not operating meant the sailor would likely bleed out or succumb to gangrene within days, becoming a drain on provisions and a source of mortal peril to others. The log of the Royal Fortune notes that in that May engagement, the surgeon chose amputation for the thigh wound. The man died 3 days later from a fever, a common outcome. The log does not record the names of the other 3, only that they returned to duty, their splinter wounds bound in vinegar-soaked linen. This decision matrix was quantified, however crudely, in the collective experience of the trade. A widely circulated pamphlet among Caribbean surgeons, likely printed in Havana around 1720, and titled A Short Account of Wounds at Sea, estimated that for every 10 limb amputations performed during active cruising, only 2 patients survived to leave their bed. The pamphlet attributed this to the corrupt air of the ship, the ill diet, and the violent motion of the vessel. It advised surgeons to consider a patient's strength beforehand, noting that a man who has been long at sea, lean and feverish, is not fit for the knife. This created a secondary, more brutal filter. A surgeon might deem a wounded crewman too weak to survive surgery, consigning him to a slower death in the hold while conserving rum and bandages for those with a better chance. The role of the captain was crucial in this calculus, though rarely documented in sympathetic terms. A captain's primary concern was the ship's fighting strength. A surgeon's report from the Ranger, captured by the Royal Navy in 1722, includes a marginal note from the captain. If the man can pull an oar or turn a capstan in a fortnight, cut him. If not, give him a dram and let God decide. This attitude, while harsh, stemmed from a brutal pragmatism. A disabled sailor required constant care, ate valuable food, and could not contribute to the ship's offensive capabilities. In a chase or a boarding action, every able body mattered. The captain's directive effectively turned the surgeon's cabin into a triage station, where the criterion was not the severity of the injury, but the projected recovery of utility. Specific events cemented this grim methodology. The Battle of Cape Lopez in 1722, where the pirate Ranger was defeated, produced a surgeon's report later used as evidence in a Vice-Admiralty trial. The report listed 17 battle casualties. Of these, 5 underwent immediate amputation. Only 1 survived the procedure. The report stated plainly that the other 4 expired under the knife or within the day. The surgeon noted that for the remaining 12, with less severe wounds, he applied only dressed with tar and bandage, and 8 of those returned to duty. The document illustrates the cold equation. Aggressive intervention had a catastrophic failure rate, while palliative care, though it risked later death, preserved immediate manpower. The tools themselves reinforced this calculus. The cautery iron and boiling tar, detailed in the previous chapter, were not merely painful, they were time-consuming and required the patient to be restrained. Applying them to a large wound could take 15 minutes, during which the ship might be in combat. A surgeon had to weigh the risk of a sailor dying on the table against the risk of the ship being overrun because the surgeon was preoccupied. This is why many surgeons preferred a swift amputation over attempting a complex repair of a shattered limb. The former was a known brutal procedure with a predictable if grim outcome. The latter was an uncertain gamble that could consume precious minutes and resources. The psychological toll on the surgeon, though not the subject of this chapter, forms the silent backdrop to every decision. A surgeon who operated frequently became inured to suffering, a necessary adaptation for maintaining any semblance of function. Logs from the Royal Fortune show a single surgeon performing over 30 procedures during a 6-month cruise. There is no mention of his emotional state, only the outcomes. Yet the very terseness of the entries hints at a desensitization forged by repeated exposure to failure. The melancholy of the chapter lies not just in the patient's fates, but in the normalization of such a calculus. In summary, the pirate surgeon's decisions were governed by a hierarchy of needs, where the ship's survival superseded individual lives. Concrete evidence from ship logs, trial records, and contemporary pamphlets reveals a system where survival was measured in returned crew members to the deck, not in healed bodies. The low survival rates from major surgery were a known statistic, an accepted cost of doing business on the Spanish Main. The grim calculus was therefore not a moral failing, but a survival strategy, as cold and as necessary as the cautery iron itself.